So welcome to the class of this. We are going to discuss the GTG number 17, the investigation and treatment of couples with recurrent first and second trimester miscarriage. This guideline is very important from examination point of view. You will always have SBA or EMQ from this particular guideline. So there will be at least 20-25 slides. Please listen carefully, take down the notes wherever required. Okay. So what is miscarriage and what is recurrent miscarriage? Miscarriage is defined as a spontaneous loss of pregnancy before the fetus reaches viability. The term therefore includes all pregnancy losses from the time of conception until 24 weeks of gestation. So 24 weeks is the period of viability in the UK. Okay. Recurrent miscarriage is defined as a loss of 3 or more consecutive pregnancies. Okay. It affects 1% of the couples. This is one of the SBA. How many percentage of couples will have miscarriage, recurrent miscarriage? It is 1%. Okay, who are trying to conceive. It has been estimated that 1 to 2% of second trimester pregnancies will miscarry before 24 weeks of gestation. Okay, so recurrent miscarriage is a loss of 3 or more consecutive pregnancy losses. Okay, now etiology, they have divided into 8 factors. These 8 factors, we will see what are those factors, then what are the investigations which are required for that particular factor, and what is the treatment if that particular factor is positive. That is why, otherwise this particular guideline, if you read, it is complicated, 60-70 pages, and if you divide this in this particular way and listen carefully, you will understand it in a better way. After that, you read this particular guideline after my lecture. Okay. So first is epidemiological factor, second is antiphospholipid antibody syndrome. Then they talk about the genetic factors, in which there are 2 factors which they are talking. One is a parental chromosomal rearrangements, and second is a embryonic chromosomal abnormalities. So in genetic factors, both parental as well as embryonic factors they are taking into consideration, the parental chromosomal rearrangements and embryonic chromosomal abnormalities. Next factor is anatomical factors, in which you have 2 things. One is a congenital uterine malformation, and the second is a cervical weakness. Okay. Fifth is the endocrine factors. Sixth is the immune factors. Next is the infective agent, and further is the inherited thrombophilic defects. And there are many SBAs and EMQs in each. Okay. So we will have 3 or 4 slides for each, and then we'll discuss the SBAs which are asked. Okay. Coming to the epidemiological factors. So maternal age and number of previous miscarriages are 2 independent risk factors for further miscarriage. Okay, what are the 2 important factors? One is a maternal age and another is a number of previous miscarriages. And these are 2 independent factors. What does it mean? If she has got a previous 3 miscarriages, the chance of miscarriage is going to increase. Not only that, the maternal age, if she is higher maternal age, the chance of miscarriage will be increased. And if there is a combination, okay, then it will be a worsening situation. Okay, the risk will be further increased. Okay, so they are independent risk factors. Even maternal age alone can affect. And even if the maternal age is less, but she has got a multiple previous miscarriage, that can also affect or increase the risk of previous miscarriage. That is what they want to communicate. Okay. Now, advancing maternal age is associated with the decline in both the number and quality of remaining oocytes. A large prospective registered linkage study reported the age-related risk of miscarriage in a recognized pregnancy. Please take the photograph of this. This is a very typically every alternate exam they are asking the miscarriage rate at this particular age is this. They will give you that the patient has conceived this age group. She has got a previous miscarriage. This what is the chance of miscarriage again. Okay. Now this particular chart is also there. No, there is no chart. They have given in a descriptive manner. Okay, that is, I have just tabulated this here. But how to remember? Okay, I have divided it into 2 tables. One is on right side, one is on left side. First, concentrate on this table. Okay, you will see 20 to 24 is the list, which is 11%. Okay, the list. This is going to be your young reproductive population with the lowest risk of 11%. Okay, just add 1 and 2%. We know that teenage pregnancies are at a higher risk. So 12 to 19% will have add to 13%. Add 1, it will be 12%. Okay, so 25 to 29 is 12%. The lowest is between 20 to 24, which is 11. After that, it becomes 12, and before that, in teenage, it becomes 13%. Okay. Now the next subgroup which is more frequently asked are these. Okay. So at 30, it will be 15%, half of 30. At 35, 25%. Okay, just add to it. 40, it becomes 50. Okay, 51 is there. Just remember, even if you remember 15, 25, 51, and this is more frequently asked. Her age is 45%. What is the risk of miscarriage? It is 93%. This is more frequently asked, but any of these can be asked. And how to remember that I have told. At 30 it will be 15, it becomes half. Then 35 just becomes 25. 40 it becomes 50. Okay, and 45 more frequently asked is more than 90%. Can you have you understood this, and will you be able to remember? Because this is a frequently asked SBA. Is it clear?
Yes, sir.
Yeah. And note down all these in your wherever you are writing numericals. No, all these numericals which I am discussing, please note it down at one particular place, and you will listen to this lecture again. Okay, I'll upload this on the YouTube. Then previous reproductive history predicts future pregnancy outcome. Risk of recurrent miscarriages increases with each loss up to 40% after 3 miscarriages. This is also SBA. There is a history of previous 3 consecutive miscarriage. What is the risk? It comes to 40% after the 3 miscarriages. Okay, previously in the last slide we have seen with respect to the age, but with respect to recurrent miscarriages, it comes to 40% after 3 consecutive losses. Maternal age further worsens the prognosis. Smoking and caffeine may increase miscarriage risk in dose dependent manner, but evidence is inconclusive. Heavy alcohol intake is toxic to the fetus. Even moderate use, more than 5 units per week, may raise miscarriage risk. Video display terminal use does not increase the miscarriage risk. Evidence on anesthetic gas exposure is conflicting. Obesity is linked to the high risk of both sporadic as well as recurrent miscarriage. Okay, so remember these particular factors. What are the risk factors? Sometimes, they ask you what is the evidence with respect to this. They will give you the risk factor and will ask what does the evidence say. Okay, so and they will ask you to identify the correct sentence. Okay, so for that we should know smoking and caffeine evidence is inconclusive, but they increase the miscarriage risk in a dose dependent manner. However, the evidence is inconclusive because smoking, caffeine use, they are more common, but what is the relation? Increase in a dose dependent, but the evidence is inconclusive. Then heavy alcohol intake is toxic, may raise the miscarriage risk if it is more than 5 units per week. Okay, or they may ask you this as a SBA. Okay, then video display terminal, if she is in IT sector and working in front of some video display, it does not increase the miscarriage risk. Okay, the question may be framed in any way. Evidence on anesthetic gases conflicting. We'll go ahead with obesity, the next best practice sporadic in abortion care. Actually, next are this is next hardly factor, 5 minutes. We are discussion. To see 8 factors. Now we are discussing about second factor. The slides were not clear. That's why I'm going in details. What are the diagnostic criteria? We know well that there are 3 or more miscarriages before the 10 weeks of gestation, or 1 or more fetal loss after 10 weeks of gestation, where the fetus is morphologically normal. 1 or more preterm birth before 34 weeks due to the placental disease. Okay. Now the epidemiology here also SBA can be asked. What is the prevalence of antiphospholipid antibodies in the general population and in patients where there is a recurrent pregnancy loss? Okay. So if it is a population you are dealing with recurrent pregnancy loss, almost 15% of the ladies, females will be positive for these antiphospholipid antibodies. Okay, in patients of recurrent miscarriage, while in low risk pregnancies or in general population it is less than 2%, not 2%, it is a less than 2%. Remember, okay, in general population, then if you screen for these antibodies, less than 2% will be positive. But if you screen these patients with recurrent miscarriage, there will be 15% patients will be positive for antiphospholipid antibody. And live birth rate, if you don't treat these female, it is less than 10%. So as low as 10% if there is a no treatment which is given. Okay, so live birth rate is very, very minimal in antiphospholipid antibody without treatment. Mechanism they won't ask you, but I'll just read from understanding point of view. It inhibits the trophoblast function and differentiation. activates complement system causing inflammation at maternal fetal interface, then thrombosis of uteroplacental vessels in later pregnancy, and heparin can reverse the effects of on trophoblast and complement based on in vitro studies. So it is related to trophoblast function also and complement system also, that causes the inflammation at the maternal and fetal interface. Okay. Now coming to the test. Okay, antiphospholipid antibody. Who should be tested? All women with recurrent miscarriage having first trimester miscarriage, or all women with one or more second trimester miscarriage. You need to do this particular antiphospholipid antibody testing. So what are the key points to remember? It should be done at interval, not during the pregnancy. After the abortion event or before the pregnancy, you have to do. You have to repeat the test after 12 weeks. So 2 tests positive at or more 12 weeks apart. Then what you are going to test? You are going to test LA and ACL. Okay, that is LA is lupus anticoagulant or anticardiolipin antibody. Okay, and lupus anticoagulant will be tested by dilute Russell Viper Venom time and plus platelet neutralization. So this is the test which is used for lupus anticoagulant. Okay, for LA you have DRVTT. Okay, and for anticardiolipin antibody you test IgG and IgM. They are measured as a phospholipid units. Okay, IgG is measured as a GPL, that is a IgG phospholipid units. IgM is measured as a IgM phospholipid units. They should be more than 40 units. Okay, so that is the medium or high titer. So anticardiolipin antibodies positive in a medium or high titer. Okay, via ELISA. Then transient infection can cause false positive, and sample quality and test standardization affect the result. So the question is asked here also, the way the tests are performed and these particular values. Okay, 40 when you will consider positive and all. Okay, and previous slide regarding the percentages of antiphospholipid antibody positivity in the population, in the low risk population also, and in the RPW population also, or recurrent pregnancy wastage population also. Now coming to the treatment. So treatment, standard treatment is a low dose aspirin plus LMWH. But what are the treatments recommended? One is a low dose aspirin plus unfractionated heparin. This is very useful, unfractionated heparin, but it is proven combo to be significantly, it increases the live birth rate, reduces the miscarriage rate by 54% versus the aspirin alone. And what are the safety risks? Heparin does not cross the placenta, so there is no fetal bleeding or teratogenicity. However, maternal risk with unfractionated heparin are more: bleeding, allergy, heparin-induced thrombocytopenia. Long term, it can cause osteopenia, vertebral fractures, etc., etc. And these are not there with the LMWH, so that is why it is preferred. Okay, the efficacy is similar to unfractionated heparin. Advantages are less HIT, that is heparin-induced thrombocytopenia, less osteoporosis, and there is a once a daily dosing. Okay, and it is safe in pregnancy. Then aspirin alone is less effective than aspirin plus heparin. It is safe, no adverse fetal effects in RCT for preeclampsia prevention. Corticosteroids, no improvement in the live birth rate, versus an IVIG less effective than the LMW. So you just have to remember this is the treatment, recommended treatment. Okay, and what are the disadvantages with the unfractionated heparin? Okay, so this is I think this finishes the antiphospholipid antibody factor. Now third factor is the genetic factor, in which there are two things which we are going to discuss. One is a parental chromosomal rearrangement, and third is a embryonic chromosomal abnormalities. So first is a parental chromosomal rearrangement. What is the prevalence? Okay, prevalence is around 2 to 5% of couples with recurrent miscarriage have one partner carrying a balanced structural chromosomal abnormality. Remember, the prevalence in RPW patients is around 2 to 5%. One of the partner may have structural rearrangements. Okay, so this particular value you should remember. Common types are balanced reciprocal translocation or Robertsonian translocation. These are two different types of translocation you see. Okay, what is balanced reciprocal translocation? So in this reciprocal translocation, there is a segment swap between the any two non-homologous chromosomes. While in Robertsonian, what happens? There is a fusion of two acrocentric chromosomes at the centromere. Okay, generally this is seen in acrocentric chromosomes, this Robertsonian translocation. While in reciprocal, the non-homologous chromosomes, there is a swapping between the two. Okay, so what when there is a such structural arrangements, the phenotypically they are normal, but the risk is increased during the pregnancy. There is an increased risk of miscarriage, and even if there is a live birth, there is a possibility of multiple congenital malformations and or mental disability due to the unbalanced chromosomal arrangement. Okay. Risk factors: risk of miscarriage will depend on the size and genetic content of the rearranged chromosomal segments. Okay. So this is first part, that is the parental chromosomal rearrangement. Now let us discuss about the embryonic chromosomal abnormalities. Now embryonic chromosomal abnormalities cause around 30 to 50% of miscarriages in couples with recurrent miscarriages. Maternal age effect further increases with the advanced maternal age, and pattern with recurrence. As the number of miscarriage increases, risk of euploid pregnancy loss also increases. So what happens with, one is a maternal age is advancing, second there are multiple miscarriages, but even if previous miscarriages are due to the chromosomal problems, subsequent normal or euploid pregnancy is also likely to terminate because of the risk of previous number of miscarriages, because the number of miscarriage itself is a high risk for the subsequent miscarriage. We have seen previous 3 miscarriage, 40% risk of the miscarriage again. Okay. And this also you should remember value 30 to 57% embryonic chromosomal abnormality. Parental translocation 2% or 2 to 5%. Okay. Now coming to the test, what you have to do is a karyotyping. So what will you test? This is also one of the SBA which is asked. They will give you the scenario and they will ask you the investigation of choice, and typically it is a third miscarriage. So when there is a third miscarriage, you have to carry out karyotyping on the third and subsequent consecutive miscarriage. So cytogenic analysis on products of conception from third and subsequent consecutive miscarriage. So you will find a scenario in which it is a third miscarriage and they are asking the next step, and they'll give you ultrasonography, 3D ultrasonography, karyotyping, etc., etc., etc. The investigation of choice on the third and subsequent miscarriage is karyotyping. Now you must be understanding why reading the guideline is very, very important, because you are applying this guideline with respect to that scenario. Okay. For that, you need to know the guideline in detail. Second, what you have to do, parental blood karyotyping if unbalanced structural abnormality is found in products of conception. So if your karyotyping in the RPOC is abnormal, then you go ahead with the parental karyotyping. They don't expect that you do the parental karyotyping simultaneously. First, you have to send the karyotyping of the third RPOC. If it is abnormal, then you carry out parental blood karyotype. Okay. So what are the key points to remember? Abnormal fetal karyotype in miscarriages, it has got a better prognosis in the next pregnancy. Parental balance translocation, there is a low recurrence risk and 83% will chance of a healthy child. And routine parental karyotyping is not cost effective. So parental karyotyping routinely not indicated. So do selectively if ultrasound, if fetal unbalanced abnormality is found. So with this, they may give you the history of third miscarriage, will ask you about the karyotyping of this karyotyping plus parental karyotyping, etc., etc. So you have to select only the karyotyping of the RPOC, or if the option is karyotyping of the RPOC, if positive, then the parental karyotyping, that will be the most suitable option. Okay. Is it clear? Is it clear?
Yes, sir.
Yeah.
Yes, sir.
Okay. Yeah. Now coming to the treatment options for genetic factors. So abnormal parental karyotype, refer to the clinical genetist for counseling. So sometimes the option, is what is the most appropriate step. So if there is abnormal parental karyotype, after that it will be referral to genetist for counseling. So sequence you have understood: third miscarriage, then RPOC karyotyping. If abnormal, parental karyotyping. If abnormal, then referral to the
Clinical
clinical.
genetician.
Okay. So that is what is the sequence, and they are asking you to understand at what level you have understood and what will be the next step. Okay. So options will be for these couples. Now they have got a recurrent miscarriage. There is abnormal karyotype. You have referred them. Then what are the options for them? they can have one natural pregnancy and can have the prenatal diagnosis. One. Second, they can have a gamete donation. They can have adoption. They can do the pre-implantation genetic diagnosis via IVF for translocation carriers. So these are the options which are. So one, go ahead with the natural pregnancy. Second, when the lady is pregnant, do the prenatal diagnosis. One. Second, do the gamete donation. Third is adoption. Fourth is a go for IVF, do the pre-implantation genetic testing, and if it is normal karyotype in the embryo, then you go ahead with this IVF procedure. So which one you feel is going to be the appropriate for these kind of patients where this you have everything has come positive? Which one will be the best? Yes. Any suggestion?
IVF with PGD.
Yeah, now let's see the further lines. Okay, this is what logically we feel. But what do they say? What the guideline? There is a lower birth rate of around 30% versus natural conception 50 to 70%. So if she conceives naturally, she will have a live birth rate of 50 to 70%, even if there is no treatment taken. You got it? But if you go ahead with this IVF with PGT, the birth rate will be 30%. Okay. For translocation carriers, there is going to be financial cost, there is going to be IVF burden, and pre-implantation genetic testing in unexplained recurrent miscarriage does not improve the live birth rate, and natural conceptions has got a higher success versus PGS IVF, which is around 20 to 30%. This is what the guideline says. Okay. So logically what we say is correct, but this also involves n number of things. And after that, what we have is a implantation rate and all those things will affect. Okay. So even if they go ahead with the natural pregnancy, the success rate is going to be 50 to 70%. Okay, this is one of the key points which you can remember in the genetic factors. Now we'll come to the fourth factor, that is anatomical factors. Okay, so here we are again going to discuss two things. One is a congenital uterine malformation and second is a cervical weakness. So what is the contribution to the recurrent miscarriages by these anatomical factors? So exact is not known because we do not know the prevalence of these factors in the general population. Then what is the prevalence? Reported range is 1.8 to 37.6%, and this is due to various different diagnostic criteria and techniques which are used for the various studies. Like a few people have used only 2 miscarriages, few people have used 3 miscarriages in the study. That is why the prevalence varies from study to study, and it is a wide. Okay. Then trimester association, this is the SBA which is asked. So concentrate here. Okay. Higher prevalence in the second trimester miscarriage. So when you have anatomical factors, you are likely to deal with the second trimester miscarriage, and possibly due to associated cervical weakness. So these they also have an associated cervical weakness also. Now the most frequently asked question is here: arcuate uterus will cause more second trimester miscarriage, and septate uterus will cause more first trimester miscarriage. A is the first alphabet, it does not come with the first. Okay, so arcuate goes with the second trimester abortion, then S does not go with S. Okay, so septate will go ahead with the first trimester miscarriage. Okay, so this is these are the SBs which are asked. Following abnormality is associated with the first trimester miscarriage. Okay, first trimester you talk about the septate uterus. Okay, or if it is a second trimester you talk about the arcuate uterus. Okay, this is also one of the frequently asked. Then pregnancy outcome, high miscarriage and preterm delivery rates, only 50% will deliver at term if they have got anatomical factors, and evidence limitation, mostly retrospective data is there. Okay. Now coming to the test for anatomical factors, all women with recurrent first trimester miscarriage and all women with one or more second trimester miscarriage, you are going to test for anatomical factors. So if there is a 3 or more miscarriages in the first trimester or 1 or more second trimester, we will look for anatomical issues. So what is the test? Screening. First we will carry out simple pelvic ultrasound for uterine anatomy. Suspected anatomy, if you on ultrasound, then you confirm with hysteroscopy, laparoscopy, or 3D ultrasound. 2D ultrasound and or hysterosalpingography, you do the initial screening followed by hysteroscopy plus laparoscopy or 3D USG. Definitive diagnosis, MRI role is unclear. Okay, this is what the MRI role is, indeterminate. That is what they say. But most of the time, the question asked here is that you are suspecting the uterine anomaly. So, what is the initial screening? Initial screening is done with the pelvic ultrasound. If it is on pelvic ultrasound, you are suspecting some malformation, then these are the tests which are indicated. Then you will be given option hysteroscopy, laparoscopy, 3D ultrasound, MRI, and you have to select either of this. Okay, there may be option of hysteroscopy but plus laparoscopy, but the 3D ultrasound will be better because rest of the investigations are invasive investigations. Here, this is a non-invasive investigation, 3D ultrasound. Okay. So the next investigation of choice will be 3D ultrasound. After the plain pelvic ultrasound, you suspect some anatomical defect, then you go for 3D ultrasound. Then you can go ahead with the histolaparoscopy, etc., etc. Okay. Now coming to the second factor, cervical weakness. Cervical weakness is a recognized cause of second trimester miscarriage. True incidence is unknown. Diagnosis is mainly clinical. No reliable objective test available in the non-pregnant state. Diagnosis is based on history. Second trimester miscarriage with spontaneous rupture of membranes or painless cervical dilatation. Okay, so this is what is a typical history in cases of cervical weakness. Now coming to the continuing with the anatomical factors. What is the treatment which they are saying? Congenital uterine malformation, insufficient evidence that septum resection prevents the miscarriage. So there is insufficient evidence. Okay, actually there are no RCTs on surgical correction of uterine anomalies. So RCTs are not there, but however it has been found useful. But the literature says that there is a insufficient evidence to recommend septum resection. Okay, open surgery will always have a risk of infertility and uterine rupture, not routinely recommended. Hysteroscopic septum resection is safer and case series are promising but needs confirmation with the prospective trials. Okay, so this is what is the current status. Okay, now what is the cervical weakness and cervical encerclage role? Cerclage carries surgical risk and should be reserved for women who are likely to benefit. So patient selection is going to be very, very important when we are talking about cervical encerclage. So we have to have some objective criteria or some definite criteria for putting the patient for cervical encerclage. So what is the recommendation? So when you have in women with a prior second trimester miscarriage and suspected cervical weakness, what we have to do? You will offer the serial cervical length surveillance if no history indicated cervical encerclage done. Okay, so go ahead with the serial cervical length surveillance. Okay, and if it is a singleton pregnancy, offer ultrasound indicated cerclage if the cervical length is less than or equal to 25 millimeter before 24 weeks of gestation. So if there is a previous second trimester miscarriage, what will you do? You will offer the cervical length surveillance. If it is less than or equal to 25 millimeter before 24 weeks of gestation, you will advise ultrasound indicated cerclage. This is what the guidelines says. Okay. Then further we go ahead with the cervical weakness and encerclage. Evidence from RCT shows no clear reduction in pregnancy loss or preterm birth overall, but benefit is greatest in women with 3 or more second trimester losses or preterm birth. If it is a short cervix less than 25 millimeter plus previous second trimester loss, cerclage may reduce the preterm birth below 35 weeks of gestation. So preterm birth happening before 34 weeks of gestation are reduced if the cervix is short and there is a history of previous second trimester abortion. This is what the guideline says. Then what is the role of transabdominal cerclage? Transabdominal cerclage may help after failed vaginal cerclage or with a severely shortened or scarred cervix, but carries higher operative risk. So if you have the in scenario, they have given that the previous cervical encerclage has failed, okay, or they have mentioned that the cervix is severely shortened or scarred, then you select the transabdominal cerclage. Okay, and the risk is it carries operative risk. Evidence for timing before or during pregnancy is limited. So when to do it, that evidence is limited. Okay, so that finishes the fourth factor. Okay, anatomical factor. Now fifth factor is the endocrine factor, so in which various endocrine disorders, the diabetes and thyroid disease. So what do they say? If it is a poorly controlled diabetes, like HbA1c is very high in the first trimester, that will increase the risk of miscarriage and fetal malformation risk. However, if your diabetes is well controlled and treated thyroid disease, not increase risk of recurrent miscarriage, so the risk remains same. So treated patients, well stabilized patients, risk of recurrent miscarriage is not increased. But if it is poorly controlled, yes. Then prevalence of recurrent miscarriage in this well controlled population is same as general population. Now, if the patient has got anti-thyroid antibodies, what is the significance? Okay, some studies link them to RM, but evidence is inconsistent. So if your patient is euthyroid and there is anti-thyroid antibody, then there is no risk. Okay, presence of euthyroid women with recurrent miscarriage history does not affect future pregnancy outcome. So if there are anti-thyroid antibody, but the lady is euthyroid and there is a history of recurrent miscarriage, it will not affect the future pregnancy. Okay. Then PCOS is linked to the increased miscarriage risk, but the mechanism is not clear. The markers, various markers like a polycystic ovaries, high LH, high testosterone, but do not predict a future miscarriage in ovulatory recurrent miscarriage women. And risk possibly is due to the insulin resistance, hyperinsulinemia, hyperandrogenemia, and increased prevalence of insulin resistance in recurrent miscarriage women. Elevated free androgen index, there is a poor prognostic factor for subsequent miscarriages. Okay. Now, what is the treatment recommendation for endocrine factors? Okay, progesterone is essential for implantation and pregnancy maintenance. How does this progesterone act? It has got an immunomodulatory role. There are two types of responses what we see from the helper cell. There are what happens in pregnancy. There is a shift from TH1 response to TH2 response. Okay, this is one of the SBA in part 1. Normal pregnancy response is a TH2 response. Okay, TH1 response is a pro-inflammatory response. TH2, that is T helper cell 2 response is anti-inflammatory. Okay, so what does the meta-analysis say? There is a decreased miscarriage in recurrent miscarriage subgroup, but based on 3 small trials, benefit is unconfirmed. Okay, what is the promise trial says? Vaginal progesterone did not significantly improve the live birth rate in women with unexplained recurrent miscarriage. So progesterone has got this particular role, but the promise trial says vaginal progesterone did not significantly improve the live birth rates in women with unexplained recurrent miscarriage. Okay, SCG supplementation, no benefit. Okay, then pre-pregnancy pituitary suppression, no improvement in the live birth rate. Metformin in PCOS, theoretical benefit. Okay, so meta-analysis, no effect on sporadic miscarriage risk. So overall, there is no much what you can say recommended treatment for this endocrine factor. Okay. Now coming to the next factor, that is immune factor. So there may be sometimes HLA incompatibility between the couples. So if there is HLA incompatibility or maternal antibodies, there is no proven link with the recurrent miscarriages, and routine testing of the couple for HLA incompatibility is not recommended. Okay, it is not recommended. So there are two types of natural killer cells. One is a peripheral natural killer cells, and second is a uterine natural killer cells. And these two are different. Their function is different. Their roles are different. There is no clear association between the altered peripheral natural killer cells and recurrent miscarriage. Okay, so testing is not advised. Natural killer cells may aid trophoblast invasion and angiogenesis, but higher counts not linked to the increased miscarriage risk. So what are the cytokines by the T helper cell 1 and T helper cell type 2? T helper cells are pro-inflammatory. They will release IL-2, INF alpha, INF gamma, and alpha. Okay, and these are anti-inflammatory. So normal pregnancy response is a type 2, interleukin 4, 6, 10. All are even numbers, 2, 4, 6, 10. Okay, so normal pregnancy likely to be more T helper cell type 2 dominant, and recurrent pregnancy, these patients will have bias towards TH1 response. Okay, so sometimes they can ask you the immunological factors, and some SBA can be asked. So little information from here you can remember. Normal pregnancy is a TH2 dominant response, while recurrent miscarriages will have a TH1 response, and TH2 is IL4 610. part 1 question is there, this, and these are the type 1 response. Okay, and these tests are not recommended. Okay, HL incompatibility and all these tests are not recommended. Overall, these immune tests remain research based and are not recommended for routine RN investigation. So when they are asking you the test indicated, no, so don't select these kind of test where there is no evidence. Okay. Now next about the immunotherapy, no benefit of paternal cell immunization, donor leukocytes, trophoblast membranes, or IV immunoglobulins in unexplained recurrent miscarriages. They are costly, carry risk of transfusion reactions, anaphylaxis, hepatitis, etc. What is the recommendation? Immunotherapy and anti-TNF agents should not be used outside formal research studies. Okay, so that finishes the immunological factor. Now second factor, now seventh factor, total 8 factors we are going to discuss. So seventh factor is an infective agent. So severe infections causing bacteremia, viremia can cause sporadic miscarriages. Role of in recurrent miscarriages not very clear. Criteria for recurrent miscarriage causation. So if at all we want to attribute these infectious agent to cause to be a cause for recurrent miscarriage, then it should be persistent in the genital tract, or and it should cause minimal symptoms as such. So it should be in the genital tract. But these criteria are not fulfilled by the torch infections. Okay, that is toxoplasma, rubella, CMV, herpes, listeria, etc. They do not meet the criteria, and hence routine torch screening is not recommended. Okay, so when you have a case of recurrent miscarriages, this particular screening is not recommended because they are not responsible causing a recurrent miscarriage. Because to say that they are responsible for recurrent miscarriage, they should be present, persistent in the genital tract, and it should cause minimal symptoms. Okay. Now, what is the role of bacterial vaginosis, one of the infective agents? So, in the first trimester, if it is a bacterial vaginosis is present, then definitely in the second trimester there is an increased risk of miscarriage and preterm delivery. So, association with the first trimester miscarriage is inconsistent. So, BV, bacterial vaginosis, has got association with the second trimester miscarriage and preterm, but first trimester miscarriage is inconsistent. Okay, oral clindamycin in early second trimester reduces the second trimester miscarriage and preterm birth in general population. Okay, so this is what they are talking about, the infective agents. Now the last factor which we are going to discuss in this guideline is a inherited thrombophilic defect. So what are the different thrombophilic defects, in which what we have is a factor 5 laden, that is FVL, then activated protein C resistance, protein C, protein S deficiency, antithrombin deficiency, hyperhomocystinemia, prothrombin gene mutation. Mechanism in recurrent miscarriage is presumed to be thrombosis of the uteroplacental circulation. And there is a meta-analysis of 31 studies. Okay. Now, sometimes the SBI is asked on this. You will find when you are solving the books, no, you will find they are asking about this. Okay. Now let's see what the I will try to simplify these complicated figures. Okay. So you have factor 5 Leiden, you have activated protein C, you have prothrombin gene mutation, you have protein S deficiency, you have this MTHFR mutation, protein C, and antithrombin deficiency, and various meta-analysis is also there. Now just look at factor 5 Leiden. Okay, recurrent first trimester loss, odds ratio is 2. Recurrent loss after 22nd, that means second trimester, odds ratio is 7.8. So more association with the second trimester as compared to the first trimester. Okay, and non-recurrent loss after 19 weeks of gestation, odds ratio is 3. Okay, so the highest odds you see after 22 weeks of gestation. Okay, so factor 5 Leiden, more association with recurrent pregnancy loss in the second trimester. Then you have activated protein C resistance, recurrent pregnancy loss in the first trimester, odds ratio is 3.4. Then you have prothrombin gene mutation, see the first trimester 2.32. Before 25 weeks 2.56. Late non-recurrent 2.3. So if you see here, all the odds are between 2 and 3. There is a definitely increased risk, but the more increase with factor 5 Leiden for the second trimester. So rest of the things are between 2 to 3 odds, but highest here you see 7.8 with factor 5 Leiden. Now go ahead with further protein S deficiency. Here recurrent loss odds is 14. Okay, this is going to be the higher than this. Then late non-recurrent is 7.39. Okay, here it is late non-recurrent loss is 7.39, while there is no association with this. And FVL and prothrombin mutation 2 times increases the risk of miscarriage. So if we have seen this factor 5 Leiden and prothrombin 2 times, definitely the risk of recurrent miscarriage is increased, but high risk with the after the 22 weeks 7, and here it is a 14 with proteinase deficiency for the recurrent loss, but they have not mentioned here the first trimester or the second trimester. Okay, and late non-recurrent is 7.39. Here it is going to be 7.8. Okay, so you need to be very careful in selecting the option if at all it is asked. So factor 5 Leiden can be answer if it is a second trimester, or if it is a protein S, it has got a 14, but here they have not specified whether it is, but definitely this 14 is going to be risk is going to be higher than this odds of 7. Okay, so this can also be an answer. So you need to be very selective, and there can be bias in selecting these two. But overall, if they are asking about without specifying, then just go ahead with the protein S. Okay. So next, who should be tested? Women with second trimester miscarriage should be tested for inherited thrombophilias. We know that second trimester miscarriage, definitely inherited thrombophilias, okay, are associated. We have to do screen for factor 5 Leiden, factor 2 gene mutation, then protein S deficiency, etc. So inherited thrombophilia, evidence is insufficient on heparin. So for thrombophilia, evidence is insufficient on heparin for preventing miscarriage in the recurrent first trimester loss with inherited thrombophilia. Heparin may improve the live birth rates in the second trimester. Okay. So if you have inherited thrombophilia, mainly they will cause second trimester loss, where the heparin is also effective. However, in the first trimester, there is evidence is insufficient. Okay. Then one RCT showed enoxaparin in women with late miscarriage and factor 5 Leiden prothrombin mutation or protein S improved the live birth rate to 86% versus aspirin alone 29%. Okay, so definitely here in second trimester the heparin has got a role. Okay, now what they are talking about, unexplained recurrent miscarriages. Many cases remain unexplained but have a 75% chance of successful pregnancy with supportive care in early pregnancy unit. This is actually in asked many times in part 3, where the patient has got recurrent miscarriage and all investigations are normal. Then we label this as unexplained miscarriage, and you have to counsel them and tell them that you have got a chance of 75% chance of successful pregnancy only with supportive care. Okay, prognosis worsens with age and number of losses. Psychological support may help, though not proven in RCT. Aspirin with or without heparin does not improve live birth rate and should not be empirically outside the research trial. So we should not recommend if it is an unexplained recurrent miscarriage. Aspirin plus heparin or either alone should not be used. Okay, so that finishes the very important guideline on recurrent miscarriages. Is it clear to all of you? Clear?